My name is Sandra Hurtado Rúa. I'm an assistant professor at Cleveland State University, and I'm delighted to be the chair of this session today. An overview of the session is right here. So we have 1 hour for our collaborative case study session number 13 today. And then we will have half an hour from 4:30 to 5 for a discussion. The idea is that to leave the questions to the end, but if we have time after each presentation, we will try to answer 2 or 3 questions. So for the audience, we ask that please use the chat feature if you have any question, or raise your hand at the end for the discussion to participate. And the following, the session just follow the same format as other sessions. This is right here, an overview. So now it's my pleasure to introduce Dr. Susan Gauthier, and she will be talking about QSM as a new imaging biomarker in multiple sclerosis.
Yeah, thank you for this opportunity for us to present in this collaborative case study session. My collaborators, Sandra and Elizabeth, will be presenting after me. And so my job here is really just to sort of set the stage. I'm an MS neurologist. My research is translation of quantitative imaging tools to study multiple sclerosis. And most of my recent effort has really been focused on quantitative susceptibility mapping. So I'm going to talk to you about the clinical translation of QSM, the work that we've been doing to try to establish this as a biomarker for disease progression, as well as for treatment response in multiple sclerosis. So my outline, I'm going to give you a very brief overview of multiple sclerosis for those of you that are not familiar with the disease. Our target, now we're targeting chronic active MS lesions. I'll talk about what those are, and I'll talk a little bit about what we're doing with quantitative susceptibility mapping, or QSM, to target these lesions. We'll talk about the histopath and in vivo validation that we've done to date, how we're trying to relate this to disability. We've identified this trajectory of inflammatory change within these lesions, how we can harness this and potentially use this in future studies. And of course, ultimately, everything is about improving patient care. So how can we detect an influence of treatment on these lesions? So an overview of the sort of the disease course of MS. Now, patients spend a number of years within what we call the relapse remitting stage of the disease. This is where you have a neurological episode. You see changes on the neurological examination, and you can see that there's an increase in disability. Now, there can be improvement, complete improvement on the exam, or patients may have residual disability. So the accumulation of these relapses over time can lead to accumulation of disability. And then after, say, 20 plus years in the relapse remitting phase of the disease, patients go into what we call the secondary progressive stage. Patients lose their relapses, and they then start to have this slow, steady decline in ambulation, but they also have cognitive impairment. Not quite as severe as some neurodegenerative disease such as Alzheimer's, but they have more of this slow subcortical cognitive issues. Now, there's also a preclinical stage of the disease. This has been highlighted more recently, I would say in the past probably 10 or so years, where we now recognize that patients can have the disease subclinically manifested by having a number of MS lesions on their MRI. So these yellow arrows are inflammatory lesions on the MRI. So these are new lesions that are occurring over time. And in the preclinical state, you can have an accumulation of these lesions. So when the disease actually starts is actually unknown, and before a person actually has their first symptom of the disease. There's also something called primary progressive MS, which is not on here. These patients are generally older when they receive the diagnosis. It's the minority of the disease of the patients. And they tend to behave like secondary progressive, where they have the slow progression through their disease. But importantly is this red line, that there is a degenerative component to this disease that marches right from the beginning of the disease. So we want to understand factors that are leading to the progressive stage. So why do people transition? We want to obviously prevent that transition. And once they're in progressive disease, if they've gone there, we want to be able to treat it. So if we understand why people are transitioning, maybe we can therapeutically target it. Just a basic review of what we see on the MRI of these scars, these chronic scars. You can see on a sagittal film here that the scars are generally perpendicular to the ventricles, and that's because these lesions form perivenular, caused by perivenular inflammation around these draining venules that are going into the ventricles. So they cause these like finger-like extensions that are actually called Dawson's fingers, and these are pathognomonic for MS and very helpful to establish the diagnosis. Early stage of the disease, you can see that patients can have a mild to moderate burden of these lesions. But as the disease progresses, you see that these lesions start to consolidate together. There's some expansion, and people end up with this big mass of lesions around their ventricles. And also, as noted earlier, there is this neurodegenerative component to the disease, adding to the complexity. It's not just about the scars. And you can see, compared to healthy control, that the ventricles of a relapsing patient are ballooned out as compared to the healthy control. As you go further into the relapsing remitting phase of the disease, more ballooning, there's deepening of the sulci. And then by the time you get to secondary progressive MS, this is quite a diseased brain with a lot of volume loss. And I just want to mention that the spinal cord is absolutely involved in MS. We're not going to talk about this when we talk about our QSM. And it's the reason why we're not talking about it is because it's very difficult to image the spinal cord, especially with quantitative imaging. So we're getting there. We're trying to get there. But right now we're not there with QSM. But it definitely contributes to the progressive and accumulating disability of these patients. So the chronic MS lesion. So for years, we've really focused on what we call the classic active MS lesion. These are lesions that represent new inflammatory attacks. There's breakdown of the blood-brain barrier, so there's leakage of gadolinium. So we can easily appreciate them on MR because they're gadolinium enhancing. So there's diffuse inflammation, there's edema, there's active demyelination, and there's some axonal loss. And all of our current treatments right now, as a secondary outcome in their clinical trials, demonstrate a reduction in the number of these new lesions. So why we've always liked them is because we can actually literally count a reduction of them. And when we're in the clinic and we're looking at the MRI, we can look very quickly to see whether we see any new enhancing lesions. Whereas the chronic lesion for years was basically ignored. And it wasn't until probably the last 5 years or so, people really started to pay attention to the chronic lesion. And histopath studies, mostly on postmortem studies, have demonstrated that there are actually two different subtypes of chronic lesions. And that's actually really an oversimplification because the chronic lesion can be an active lesion or a chronic active lesion, or also called slowly expanding. And within this category, they can actually be broken down further to see whether they're actively still causing damage or not. But for the purpose of this talk, we're just going to sort of just call them chronic active MS lesions. And then the other type are these inactive lesions. So now that we've sort of identified these in postmortem studies, we've shown in these studies that they still have active inflammation at the edge of these lesions, which cause some slow expansion, and as well as active demyelination and axonal loss at the edge. Now, multiple investigators, as well as ourselves, have demonstrated that iron is present in most microglia at the edge of chronic active MS lesions. And that's important because we can actually measure iron via MRI. And so gradient echo sequence is the most effective in detecting tissue magnetic field, and therefore is used to detect paramagnetic rims. And quantitative susceptibility mapping, or QSM, can be regarded as a post-processing technique for GRE MRI reconstruction and provides accurate localization and quantification of the susceptibility source. So a significant amount of our research effort is in the translation of QSM as an imaging biomarker, specifically for these paramagnetic rims. So just to give you an example, of what these rims look like. Okay, so over here on the left is the flare sequence. So the flare sequence is used to detect MS lesions. It's a T2 with the CSF suppressed. You can really appreciate these paraventricular lesions. And on the right here is a QSM sequence. And you can see here these lesions that have a hyperintense rim. This is what we would call a rim-positive lesion. So there's no specific criteria. Essentially, we like to see that there is a gradient from hypointensity to hyperintensity in the perimeter, and also the surrounding normal appearing white matter needs to be low compared to the rim. A criterion is actually something that we're actively working on so that we can all define it consistently. But in this patient, you can see that they have a number of these rim-positive lesions. And interestingly, we find that about 50% of patients have at least one, and people tend to have a number of these lesions. If they have one, they usually have a couple. And we're looking in to see whether this is always the case, meaning if you have a rim at one period of time, do you always tend to develop these rim lesions? These are interesting questions that we want to pursue. So part of our in vitro validation that we are detecting chronic active lesions, we combine this with our myelin imaging. We do myelin water fraction imaging. And here is QSM, myelin water fraction. And in these rim positive lesions, when we looked at myelin water fraction, we saw that as compared to rim negative lesions, those with a rim had lower myelin water fraction, meaning there's more tissue damage. And that's what you would expect from a chronic active MS lesion. And this is work that Sandra collaborated with. And we also saw that a thicker QSM rim, those lesions with a thicker rim, you had more myelin damage. The next paper that we did to demonstrate this in vitro validation is that we combined our QSM with TSPO PET imaging. Now, TSPO PET, there's a number of different ligands, and we used a first-generation ligand called PK11195. And this binds to activated microglia. And so what we demonstrated here by combining QSM with this PET ligand is that the lesions with a hyperintense rim have more uptake on PK PET as compared to those without a rim. And it's demonstrated here, rim negatives, lower PK uptake compared to rim positive. And again, Sandra collaborated on this work. So histopathologically, we also validated this. So this is in postmortem study. You can see here a rim positive lesion. It has a dense rim of iron and a dense rim staining for CD68, so that's for microglia. And there was co-localization of the CD68 with our TSPO ligand. And as compared to a rim-negative lesion, has a very fine rim on iron and on microglia staining and TSPO. A more recent study was an in vitro study where we actually wanted to demonstrate that these inflammatory cells that are present at the rims actually have markers of activity, okay? So in these rim-positive lesions, we demonstrated that they demonstrate markers of M1 and so ferritin and INOS, as well as M2. And these are markers of inflammation of the microglia. So the microglia are just not dormant, they're there and they're active. M1 is for a pro-inflammatory, meaning they're actively doing damage, they're more neurotoxic, more demyelinating, as opposed to M2, there's cleanup. These are microglia that are there to sort of clean up the demyelination. So if you have M1, you should have M2. So this is demonstrating that these are very active lesions, as opposed to these QSM negative lesions. So the next is to associate this with disability. In a cohort of about 159 relapsed and remitting MS patients, we counted all of the rim lesions. About 37% of the patients had at least one rim lesion. And you can see here that what we did is we wanted to look at disability as measured by cognition as well as ambulatory dysfunction on our EDSS. So in cognition, we looked at three different scales, and this is part of the BCAMS composite. So BCAMS is a screening tool to look for cognitive dysfunction in MS. It's made up of symbol-digit modality, California Verbal Learning, and brief visual memory test. And you can see that just on this simple univariate analysis that there is a, apologize for that, that there is a difference between patients with one rim positive lesion, meaning that they seem to have a little bit more cognitive impairment, at least on two of their scores, and they seem to have a little bit more disability. And when we looked on the MRI, just on this t-test, you can see that there are differences. There's more cortical thinning in patients with just one rim lesion, more thalamic loss. Importantly, patients with a rim positive lesion also have more lesions in general. And this is work in collaboration with Sandra. This is a multivariate, multivariable model, and this is looking at essentially the mean difference in performance on all of these cognitive measures as well as on EDSS. And this is the confidence interval of the difference between those patients that have one rim positive lesion versus no rims. Importantly, there is a strong association with lesion volume with the outcome as well as having a rim. Therefore, we need to consider total lesion volume in this analysis. So as a patient's lesion burden in general increases, having just one rim positive lesion really causes this separation in these cognitive scores as well as on disability. When we looked at cortical thickness, controlling for age, we can see that patients with just one rim positive lesion have more cortical thinning, suggesting more of a neurodegenerative component to their disease. But by the time they're about 45 years of age or so, age seems to dominate this relationship. So on to sort of getting into these lesions as far as how much inflammation they have and can we quantify this? And what we identified very early on when in our QSM MS studies is that there are different susceptibility levels in general in MS lesions based upon lesion age. So this was a cross-sectional study back in 2014, and all of the lesions, so each block is an individual lesion, and they were each age, so we knew exactly how old these lesions were. And lesions that were really old essentially had a very low susceptibility. In the orange, those lesions were enhancing lesions, so those were the newest lesions. They were also low. And we saw that those lesions that were just a little bit older than the enhancing lesions had a high susceptibility. And in this study, And in this study, we had a follow-up of 6 months, and we saw that there was a jump in susceptibility in those enhancing lesions. All of the other lesions remained pretty stable. So this sort of led to a speculation that there might be this trajectory of change in susceptibility based upon a lesion's age. So this was a longitudinal study of 32 gadolinium-enhancing lesions. So these were brand new lesions. And we categorized the lesions as having eventually a rim versus not developing a rim. Now, developing a rim generally occurs very early on during lesion development. So within about 3 months or so, we generally will see a rim. If we're going to see one, it becomes more prominent over time. But when we break these out, and this was also work that Sandra did with us, you can see that all lesions increase in susceptibility initially over the first year, but rim-positive lesions continue to climb. So they have a higher peak, and they remain higher longer than rim-negative lesions. So we think that what we're seeing here is a development of the chronic active lesion that remains in a state of chronic activity for a number of years and slowly decreases. And that's what we're demonstrating here on this schematic. Why this is important is because if we're going to target these lesions therapeutically, we need to understand this. We need to understand that if we're seeing a reduction, it's due to a therapeutic effect and not related to just the natural course or the natural history of these lesions. We're starting to look at a treatment effect, and this is work that Elizabeth is collaborating on. And we have 18 patients treated with dimethyl fumarate. This is a drug that we know gets into the central nervous system versus another drug called glatiramer acetate, which does not get into the central nervous system. Why this is important is because, again, we're talking about CNS-based inflammation. So, you know, we feel that a drug needs to penetrate that blood-brain barrier to affect the microglia within the brain. And all of these patients had rim lesions. And we looked over time at this trajectory of change on susceptibility. She fit a linear effects model, and we saw that there was a larger decrease in susceptibility in rim lesions in patients treated with Tecfidera as compared to Copaxone. Why I like this figure is that it really shows the dynamic and the change as well as the variability of our data. And I think all of you can appreciate how difficult this data is to work with when you have something that jumps around like this. But we do find that the overall trend is different. But importantly, we need to get to be more specific about this trajectory. And we feel that we need to assign a lesion age to help identify that accurate inflammatory stage of the rim-positive lesion. And we need to, the next thing we can also, in addition to treatment effect, we can explore clinical variables that might influence how long a chronic active lesion remains active. Maybe in patients that have progressive disease, that lesion remains more active longer than somebody with earlier stage disease. These are all interesting questions that we want to ask. But as I stated before, I think it's so important when consider targeting with treatments, we need to understand the accurate lesion age. And Elizabeth's going to go into this in her talk. So in conclusion, we have significant interest in moving QSM forward as a lesion biomarker in MS. And QSM rim-positive lesions have a relevance in the disease. And I think I established that in this talk, but remain with significant challenges to establish them as a true biomarker. And Sandra's going to go into what it means to establish this as a biomarker. And I think that will be it. And these are my acknowledgements, and thank you.
It's my pleasure to introduce Dr. Elizabeth Sweeney. She will be talking about QSM analysis, and she will target lesion type identification, and lesion age estimation. So
thank you. Let's see. Can you guys see my screen? Great. So I'm going to be talking about image analysis tools for quantitative susceptibility maps in multiple sclerosis lesions. But I'm going to motivate this by what Susan talked about before. So one of our overarching goals is to evaluate disease-modifying treatments in terms of how they act on the longitudinal behavior of QSM rim-positive lesions. So Susan gave a great introduction to these chronic active multiple sclerosis lesions. And this is kind of a biomarker, and we'd like to see how treatment acts on this biomarker and the longitudinal behavior of it. So this is one of those QSM rim-positive lesions right here. One of the things that I've been working on is automated ways to identify rim-positive lesions. So with a PhD student, Han Zhang at Weill Cornell, we've been working on deep learning methods to identify these rim-positive lesions. I've also done some work with Taki Shinohara and Carolyn Liu on identifying chronic active lesions on phase imaging. And for this talk, we are actually going to take that complex information from the QSM rim-positive lesion and collapse it into a summary statistic. So right here, I have a QSM rim-positive lesion. This is a mask. We get a histogram of intensities over this QSM rim-positive lesion. And we can calculate a number of statistics over this histogram. The one that I'll be using for this talk is we take the mean, but we've experimented with using different statistics. And I've also kind of been thinking about maybe using the density itself and modeling that. So again, one of the overarching goals is to look at how treatments impact the longitudinal behavior of these lesions. Susan went over the longitudinal behavior of the QSM rim-positive lesion. It starts out, there's no signal on the QSM when a lesion forms. Then we have this chronic active stage, and later that inflammation subsides. And what we're asking is, can a treatment maybe push down this inflammation, maybe at this point or at a later time point? And so I'm going to go through the ins and outs of the statistical model that we use to compare Tecfidera versus Copaxone that Susan introduced. We had some difficulties because this is observational data. It wasn't a randomized clinical trial. So I want to give some of the ins and outs of the statistical modeling for that. So we had a cohort of 34 patients with 91 QSM rim-positive lesions. And our hypothesis was that because Tecfidera has a central nervous system anti-inflammatory effect, that it would reduce susceptibility among QSM rim-positive lesions more than Copaxone. And so this is the data that Susan showed before. Again, you can see the variability, but you do see a downward trend in both Tecfidera and Copaxone. And these are our baseline characteristics. So overall, most of these there was no statistically significant difference between the two groups. But one thing that I do want to show is that there is a difference in disease duration. So people on Copaxone had a shorter disease duration than those on Tecfidera. That's due to the fact that Copaxone is normally used as an earlier line treatment than Tecfidera, and it's something that we are interested in adjusting for. So here's our model. So we're going to let I index a patient, L index a lesion, and T index a time point. We have our mean QSM at each time point. We regress that on time, an indicator of being on the drug Tecfidera. This is our coefficient of interest, our time and Tecfidera interaction. Then we have the log volume of the lesion at baseline, the sex of the patient, the disease subtype at the time that the lesion at the time that they started the treatment, race, age, disease duration, and expanded disability status score. We include a random effect for subject and a nested random effect for lesion within subject. And so one of the big things you may notice when you look at this plot is that the time of follow-up for the Copaxone patients is much larger than those in the Tecfidera group. So patients on the Tecfidera group were followed on average for 3.1 years, while patients in Copaxone for 5 years, and that was statistically significant. So we used inverse probability of sensor weights to account for the difference in this follow-up time. And so we use the Cox proportional hazards model to model the sensor time for the patients. And so that model is shown right here. Only treatment was found to be statistically significant in this model, and we use the model to predict the probability of being censored, and then weighted each subject by the inverse probability of being censored. So these are our results. So we bootstrapped the entire procedure to get bootstrapped 95% confidence intervals. Those are shown on the right. And our coefficients are shown on the left. So we do see a reduction in susceptibility for the copaxone group. So on average, it reduced by 2.21, holding all other factors constant. But we do see that our interaction term, our term of interest, is also statistically significant. So beyond what we saw in the copaxone group, patients in the Tecfidera group saw on average a 2.82 decrease in susceptibility above beyond those in the copaxone group, holding everything else constant. Being a male was found to be statistically significant, and also race was found to be statistically significant. And so there are a few limitations in the model that Sandra and I are planning to work on. We don't really have a causal interpretation. When we get more data and we can maybe use these automated methods to segment rim-positive lesions, we'd like to do some causal modeling, maybe some propensity score analysis and such. We'd like to adjust, we adjust in the model for disease duration, but kind of digging more into that problem of disease duration and treatment line. We also have treatments changing over time, so we'd like to adjust for that in the model. And then the last part is something that I'll talk about and that Susan alluded to. When we're working with this data, the inflammatory stage or the age of the lesion is unknown. So maybe the patients in the copaxone group are just farther along and have leveled out more than those in the Tecfidera group. And is that causing us to see something that isn't really there? And so for lesion age, I want to explain it with this schematic here. Along the x-axis, I have time, and this is mean QSM intensity. Say that this dotted line is the baseline scan for two patients. I might have a patient who is in their chronic active stage at baseline versus another patient whose lesion has just formed at baseline. And so you can see that these data are temporally misaligned. And so we worked on both cross-sectional and longitudinal methods for estimating the age of these multiple sclerosis lesions. So I'll start out with, I think, the harder problem. Can we estimate lesion age from a single MRI scan? So if somebody gives me an MRI scan, can I say maybe this lesion right here is 6 months old, this one over here is 10 days old, and this one is 3 years old? As Susan said before, it's really, really difficult to know the age of a multiple sclerosis lesion. Patients come to the clinic on average every year, and if a lesion forms between that time, you don't know if it's a year old or if it's just a couple days old. The only way to know the age of a multiple sclerosis lesion is if we catch it in its enhancing phase. So when a patient gets a T1 weighted gadolinium scan, if the lesion shows up as hyper-intense on that scan, we know that lesion is new. So we capitalized on this to do our lesion age estimation. We have longitudinal follow-up for patients. So we found lesions that were enhancing. So this is shown right here in the first column. We have enhancing lesions. And then we just calculated the age of a lesion from time to enhancement, so that we would have a gold standard of age for this lesion. So for example, this patient was scanned a little more in the beginning, but we have a scan at 4.4 months, 8.4 months, 1.6 years, 3 years, and 4 years. And you can see it's enhancing. This is the T1 weighted with contrast. It's enhancing and then not enhancing later. And these are the modalities that I'll use for the prediction. We have T1 weighted with contrast, T2 weighted, fluid attenuated inversion recovery or FLAIR, our QSM. You can see that it's not really showing up until later, just as Susan had talked about. And then we have hand-drawn masks at each time point. And so this plot right here shows the data that we have for the analysis. So this is time in years. This is gadolinium enhancement. Each row on the plot is a lesion. They're colored by subject, and each dot on the plot is an MRI scan. So we have a fair amount of follow-up. We had 32 patients with 53 new lesions at 244 time points. And this, again, is the data that we're using for the analysis. I'm doing prediction cross-sectionally, so I'll make predictions at each time point. But I first need to address an issue. So the T1 weighted and T1 weighted plus contrast, T2 weighted and flare do not have intensities. So we use work developed by Taki Shinohara to do image intensity normalization. So we took a automated segmentation of normal appearing white matter and transformed the images into z-score units of normal appearing white matter so that they had units that were comparable within a patient and between patients. The next thing that we did was calculate radiomic features. So this is a way to summarize the distribution within the lesions. So over the QSM, we get the histogram, and then we calculate a number of summary statistics to describe this histogram. We did a training and validation. We started with our full data set. We limited lesions that were 50 millimeters cubed or more. In the paper, you could see this for a number of different size cutoffs, but this was the one that performed the best. And then we randomized 2/3 of the patients to a training and 1/3 to a validation and fit a random forest model. We used kind of a straw man for this analysis where we compared the performance of our model versus a model that just had demographic information. So this is a table of that demographic information. And so I'll go through 3 different modeling scenarios. One is one that includes all sequences and demographic information. One is one that just includes T1 weighted, T2 weighted, flare, and demographic. And the last is just demographic. And so not surprisingly, the demographic information does not vary much over time. So we had horrible performance. So this is the actual age of the lesion in years along the x-axis. And along the y-axis, I have the predicted age in years. So you can see these predictions are quite flat and do not follow this identity line, which would be ideal. Conventional MRI. So this is T1 weighted, T2 weighted, and flare. You can see maybe it's better. I just think it's noisier, and you don't really get good predictions there. But when we included the T1 weighted and the QSM, our predictions got a lot better. So you can see this starts to follow the identity line. We still have a little bit of errors, but the performance is much better. And breaking that down into numbers, the demographic and conventional had mean and median absolute errors of close to a year, whereas the all sequences had a median absolute error of about 6 months and around 7 months for mean absolute error. So the performance was much better when we included the QSM and the T1 weighted image. And so this gives us, we now know there is some signal in the MRI that we can use to predict the age of lesions. Future work is to validate findings in a larger cohort of patients. That's a bit difficult because it's hard to get these enhancing lesions and to get a really large amount of data for this problem. We'd like to incorporate other imaging types such as DTI to see if there's signal for aging lesions in DTI. We would also like to extend these models to model the density rather than just using radiomic features. I'm going to talk just very briefly about extending this to longitudinal models. And so because what we want to do with this is analyze the longitudinal trajectories, there's no reason to use cross-sectional information to age these lesions. We can actually take these curves and try to temporally register these using techniques from functional data analysis. So this is a simulation. I'll show you the math behind it in just a second. But this is some simulated data that has been misregistered from the QSM. And this is data that has been registered. And you can see you get that pattern that we expect. And so we use a shift registration. The registration criteria is right here. And then we iteratively minimize this using the Newton-Raphson method. So this is our kind of an idea for our curve registration, and this is ongoing work. But the idea is if we can get this offset and we can know how much the curves are shifted by, we can use that in the model and adjust for the age of the lesions to help us solve this treatment problem. So I would like to thank my collaborators, especially Sandra and Susan. And great, I'll turn it over to Sandra now.
So I'm going to wrap up the session with quick talk, and it's going to be a little more light, more about looking into the future and what is the future work that we are actually looking forward with QSM. And a little bit, so I'm going to start with a little review of what Susan talked, and then I will go into a bit of what Elizabeth presented, just to summarize where we are. And then I will go into the review of biomarker. So what does it take for QSM to be pushed to the next level, right? And I will talk about few statistical challenges that I see are important for us as a group of statisticians to think about it. And in number 4, I will kind of review some of the methods very quickly that we have used so far and what we thinking about using next. I finished the talk. Some conclusions. So background. So this is referring to more about what Susan talked on. So what we have done. So we have shown that QSM and rim-positive lesions maintain a hypertense rim. The susceptibility is higher. And also there is a relationship with lower myelin compared to those with a negative rim. We have also worked on the association between QSM and inflammation. And we have also talked about this temporal trajectory that is different for QSM lesions. Is different when you have a positive rim or a negative rim. And so what we are looking now is to translate this quantitative QSM or the number of rim-positive lesions, or both, to actual clinical endpoints, such as physical and cognitive disability. And this is work in progress that Susan talked about. So, but as I said before, I think the goal for us is to elevate QSM. We have shown a lot of association to actually a biomarker. So what is a biomarker? So biomarker, what do we need to do next? So it's a measure you can objectively obtain. And this is a lot of the work that Elizabeth kind of talked about today. How can we automate, create automatization for this measure to make the work easier? Because right now it's done by radiologists. So it takes a lot of time, and also so that's most of the work that Elizabeth presented today. And the second one is the evaluation. And the evaluation includes just the statistical models to create QSM as a biological measurement that is related to treatment, right? So there are different types of biomarkers. We can think about a diagnostic biomarker or predictive biomarker that actually predicts the likelihood of a person to have an effect from an exposure to a treatment, or a prognostic biomarker that's related to a clinical event, or both. So there are both different objectives, but prognostic is associated with the differential disease outcomes, while the predictive discriminate the response to actually treatment. There are all types of biomarkers, but I think we are looking here into the prognostic and predictive kind of characterization of QSM as a biomarker Well, both we need to characterize and measure QSM or the presence of rim positive and rim negative lesions, and the interaction with treatment. The interaction will be we want to predict a biomarker or simply just kind of additive effect if we are looking from prognostic. But we want to see these two variables, we'll adjust for other ones, how do they impact an actual clinical outcome. So this is from NIH. It's like the steps of any biomarker. And I think we as a statistician have a lot of work. We do a lot of work with analytical validation. We do a lot with clinical validation. And this is more or less where we are, where we want to use large cohorts to actually evaluate this QSM in the context of clinical outcomes. So what does it mean, really, validation? So it's not only to have a large data set, but also is evaluate either the utility for clinical practice or for drug development. Well, what we have done so far is, which is very important and it gets us there, but it's just try to see the associations between these, between QSM and potentials in practice. And we have done this through two different measurements. One is the intensity itself, as Elizabeth mentioned before. And also the second one is through the number of rim-positive lesions, as Susan also mentioned before. And one example of this is this work in progress, that a paper we recently submitted that is related to, so how can we evaluate the impact of QSM on actually the clinical variable disability, because that will be important. It's crucial to validate the potential of it. In the NIH manuals and the literature also usually talk about clinical outcome assessment and biomarkers. In the literature, so there is an important thing for us here, because when we are thinking about the biomarker itself, all the models have QSM, if QSM is the biomarker, as an outcome, right? But here, when we want to actually associate or see the utility in clinical practice, we want to flip around. We want to say, my clinical outcome is just my response variable. So my explanatory variable is the biomarker. So it's a little bit different from the setup in the statistical thinking of the model. So this is the data. I will go through this really quickly because already Susan and Elizabeth talked about this. So we are dealing with large data sets and the imaging protocol, which we can have several imaging endpoints. So Elizabeth just went through this, so I'm going to go here at this. There is a lot of segmentation and so on. And the QSM identification is both FLAIR and the QSM sequence. But there are other imaging endpoints we have worked with before. Susan talked about an example is the myelin fraction. And this is basically what we get. So far, what we have analyzed is just data at the lesion level. We could analyze as well ROI, region of interest level, but that's what we have. And if we look at this is for the appearance that that Susan talked about the QSM lesions. But if we really want to talk about the biomarker evaluation, so we need both. We need not only cross-sectional size, but also longitudinal, right? So the change of the biomarker must explain, or not only must be associated, but must explain the outcome. And the outcome is now clinical, right? It's no longer our response. Our response is something clinically that we are able to measure. And we want to not only see the association, but also the cause-effect relationship with that biomarker. And change is important. So it's not only cross-sectional size, but also longitudinal change. And the importance of looking at this is because obviously treatment can change the outcome without maybe affecting the endpoint, that is your clinical variable, or it can change the endpoint and know the biomarker itself, or can change both. So this is from the work in 2018, where they explained, the importance of, a causal effect in the biomarker estimation. So a challenge that we have here, I don't know if you were looking at, is that we may have multiple endpoints, so now vectoral endpoints, or multiple biomarkers. Why is that? Because of course the system are complex and multidimensional. Let me see what happened here. So this is where we start thinking about the modeling strategies. So we have neuroimaging. So we may have a vector, and if we are talking about we use the current modeling structure that we have. So we may have a vector of lesions, but the number of lesions, the dimensionality of this vector, obviously is going to depend on the patient, right? Because it's unbalanced data. But we are looking to not only look at cross-sectional, but time, evolution over time. So that imaging, we will extract a dimension of, a vector, which dimension will depend on both the patient and the time, because a person can develop more and more of this type of lesions. And also, it's more challenging when you think about that made you want to extend this to different biomarkers, not only use QSM, but maybe combine with myelin fraction and so on. So you will have K of them, it will be fixed. And with respect to the clinical endpoints, as Susan talked earlier, we may have like a disability, we may have, EDSS as gold standard, but we may also want to find a whole vector of, cognitive and EDSS together. So instead of talking about a scalar as our endpoint, we may be thinking about vector of outcomes. And remember, this will be our response variable now. We need to kind of associate this with these quantitative imaging or measure or composite scores of them, and treatment, and possibly if we are talking about predictive biomarkers, the interaction between both. Let me see how I'm doing with time. Okay. So that would be more an example of, what we're looking for. So in this case, we're talking about QSM, but we combine this with other imaging techniques, and we're looking over time, what happened. And in this case, we're following the same lesion, but in reality, we may have new lesions along the way. So the models we have tried so far for the association studies are mixed effect models with random and next effects. Multilevel growth models that are a subset of these ones, and they have a very interesting structure for the time. And what we're looking into now is joint modeling of both the disability or clinical outcome and the quantitative biomarker outcome. And ideally, extend this to kind of models that we can adjust for causal inference, because although, the process into the modeling pipeline is that at some point you kind of propose a clinical trial. I think we have, a lot of data that we smartly can think of as statisticians as a group. So how can we adjust these models to actually go and use this using causal inference? So this is a quick example of, what, we have done before, a mixed effect model where we have the QSM as our outcome, and we can adjust for multiple lesions per patient. It doesn't have to be balanced and so on, and we can adjust for several covariates of interest, a baseline, or even time-varied covariates, and extract these effects. But again, so the challenge is now that we want to flip things around, and now our outcome needs to be the clinical outcome of interest. So advantage to this model is they're very flexible. You can the interpretation is pretty easy. We can have different dimensionality of the biomarker itself over time. Naturally handle, the uneven space when we are doing changes over time on using clinical data. And we can also perform subject-specific inference with random effects. But the disadvantages is the no convergence that was documented by Gauthier and other co-authors in 2004. The normality assumptions, obviously, we could relax this. Another thing is, is how to deal with, patient level response variables when we don't have them varying over time. And obviously, if these models are used for causal inference, it needs to be adjusted, and we need to work with adjustment for that. So the second model, that is the GC curve model. So it's a subset of the mixed effect model in the sense that it adjusts for multiple lesions per patient, but now it has an orthogonal curve for the time. So you define the curve for the time, but it's flexible to model QSM again as a response variable. So the structure for the time was an orthogonal polynomial on time, especially designed for the time curve. It has a hierarchical measure mixed effect model, and they do a good job capturing the general form of the curve, but may produce very strange behavior when you are outside the range. So the interpretation, obviously, for interpolation is fine, or even at the ends, you have to be careful about that. But in general, they are really, really flexible model. But we have to start moving away from this because, again, here we are modeling QSM, and now we want to model the effect of that biomarker on the clinical outcome. So one idea here that we are exploring and working on right now is to do joint modeling. So joint modeling, I mean, just to in the same setup, kind of see how the longitudinal, say, mean QSM or number of positive rim lesions will impact the hazard or the survival probability to disability, or first disability. We can define disability based on the cognitive scores. So this is how it works. So you jointly model, let's say in this kind, we are using mean QSM for all the lesion for that patient and how that impact your survival probability or identically, your risk of disability over time. So this is what it produces. So the advantages of this model is that because you have this random effect, you can do a specific prediction, and obviously you can marginalize and get population kind of estimates. It's a very flexible framework. It's relatively easy. It was introduced by Risopoulos in 2010, and it's using maximum likelihood. It has a two-step. You can do dynamic prediction here, where the hazard probabilities, the hazard, the instantaneous risk of disability can be dynamically updated following the longitudinal evolution of the biomarker. But the problem with these models is that they need a lot of prediction and cross-validation. And the parameterization is extremely important, so you have to be careful with the parameterization. And the model assumes full conditional independence for the estimation. So that's some of the disadvantages. But I think the interpretation is pretty easy, so it's something we can use, but there are two disadvantages in the context of neural imaging, is that we have to reduce the whole biomarker to one scalar, right? Or one measurement over time. The other one is still we haven't addressed the causal effect, so it will need to be adjusted as well. And the final idea we have is just use short equation model, where we can actually introduce treatment over time and how this affect, any clinical measure like EDSS over time. So the good thing about this is that we through latent variables are kind of just taking into this dynamic of treatment change and even number of positive lesion change into modeling the EDSS. But this is work in progress, and so to summarize more time, we have shown that QSM have the potential to be a biomarker in multiple sclerosis, and not only that, we have started analyzing how this can be associated with actually clinical outcomes. So with the ability to inform clinical management of the disease and also targeting of treatment. We kind of introduced a few statistical models we have worked on for group data, and we kind of review the disadvantages and advantages of some of the models we have used. And let's see, okay. And we saw a potential of models with little adjustment that we can extend to actually apply this observational data with the idea of causal inference. So this is all. So I would just want to thank